the migration of doctors and other health workers to other countries is taking a toll on hospitals across Nigeria, as institutions have reduced the number of their outpatients and surgeries due to shortage of manpower. Now, reports show that almost all health institutions were battling with the shortage as they could not cope with the high number of patients who thronged government hospitals, which were affordable compared with the private ones. Now,
recall that the chairman of the House of Representatives Committee on Health, Dr. Osarogie, had on Wednesday last week raised the alarm that not less than 5 wards with about 150 beds had been closed down at the Lagos University Teaching Hospital, Idiaraba, due to a shortage of health workers. Dr. Osarogie said that the 5 wards had to be shut because there were no workers to operate them despite the large number of patients received at the institutions daily. He added that Luth was not the only hospital battling with the problem, as health workers lamented the heavy workload because their counterparts had left the country.
Although the Nigerian Medical Association and the Nigerian Association of Resident Doctors, NARD, could not give the exact number of medical doctors that had left the country, NARD had in January 2023 stated that a survey it conducted indicated that more than 2,000 of its members left the country in 2022. Now, joining us this morning to examine this trend, of course, is a medical doctor, a medical practitioner with years of experience, and the Secretary of the Nigerian Society of Occupational Health Physicians, Dr. Nsikak Ntia. Good morning. I hope I pronounced it right.
Yeah, I will.
Okay, Good morning.
Good morning. Thanks for having me.
Thanks for joining us.
Show, yes.
I keep arguing that this is not a, just a health problem. This is the Japa Syndrome is, it's affecting every part of Nigeria. Banks are suffering it, FMCGs are suffering it, of course the healthcare industry is suffering it, universities are suffering it also. But can you give us a seemingly clear picture of how bad it's affecting the health sector?
I think it's catastrophic, and I think it's a crisis that requires the kind of urgency I am not seeing. It isn't enough to mount expletives at the House of Assembly on mass level. At every level of society in this country, it's an emergency.
Yeah.
And I say that because, so you talked about an estimated number of 4,000 that have left the country. It's more. The UK immigration report, for example, from December to May 2022, has 727 doctors issued visas to go work. 6 months. That means last year alone, something like 1,400 would have gone.
Oh, yeah.
This post-COVID trend of very aggressive migration, because the opportunities have opened up more post-COVID globally. And that's for the UK alone. Now, we say there are about 40,000 doctors practicing in Nigeria currently. That number is an overestimate. And I was just joking with Olive earlier on that I'm in Nigeria, I'm a doctor, but I don't do patient care anymore. I'm one of those who's lost to that number.
Yeah.
It's dire. We say we have 1 to 8,000, 1 doctor to 8,000 people in Nigeria. Sometimes those numbers, they are alarming, but that's not the true picture. Because as you go further down the socioeconomic trend, that number multiplies by an order of 2 or 3. So while a socioeconomic level, class 1, or some top person, will have his doctor back and call, the guys out there in the periphery and the rural are probably 1 to 20,000 or more. So at every level, it's a crisis, it's an emergency. Worse still is that the opportunities are still opening up for doctors to go abroad and work with easier to grab work permits and visas. Therefore, this trend will continue for a few more years. It's a crisis.
Well, it is indeed a crisis. You've talked about how this has impacted doctors. And I'd like to ask exactly how, what is it about the UK and Saudi Arabia and these other countries that make these doctors, want to go there and work? There are other, like you.
Canada and Australia.
Yes,
Finland,
exactly. There are other people who have just shifted from being medical doctors who are still here, but have decided to go for less strenuous tasks or less strenuous occupations that would maybe pay them more than being a medical doctor. But what is it about these countries that is pulling our doctors and, that makes it easier for them? It's almost like you meet a doctor or you meet a nurse, a health practitioner, and the next thing you're asking is, so when are you leaving? Because it's almost certain that they're leaving.
It's the smart thing that they've done is that they've lowered the barrier for entry. When I relocated to the UK to practice, the steps were much more arduous. It was more difficult to get the work permit, it was difficult to go through IELTS, PLAB 1, 2, but even after that, to get placement was so tough. Here, they're poaching you before you start the exams and telling you potentially there's a job for you. And there's no better way to migrate than to migrate straight into employment. of that level in a developed country. It's a dream. So that's what's changed from our time when you had to go the grind, go there. I washed cars, I did everything I was in the UK before I was able to get a job and things like that. I'm just saying that that's a whole different picture now. Right? From here, you get an employment letter, you get a sponsorship letter, you get an offer. You gotta know exactly where you're stepping into. They even give you accommodation when you arrive. Come on. So they've tilted that balance. In the UK, Saudi, of course. In the Middle East, for sure. And that's the thing that's changed the game for the amount of migration. The pushers, you've got two factors here. You've got the pull factors and the push factors. These are the pull factors. Better pay, better training, better opportunities, a very conscious strategic direction as to how to drag us in. Is it perfect for us? Coming from where we are in Nigeria, it's perfect. But remember, when you go there, very often, you don't actually be able to ascend to the top or to the very core of their systems. But they use you for what they need you for, which is enough for us because that's much better than what we've got back home.
Yeah.
So that's the conundrum.
It's pretty interesting, and like she said, it's not just the UK, it's everywhere. But there's obviously something that is pushing doctors from here, to go to any country in the world, to go as far as Australia to practice there, to go to places where they never would have even imagined that they would, they have no business with, to practice there. So aside the pay, talk about the experiences of a Nigerian doctor that would make you want to go to Malta to practice. Want to go to some random country in Europe, where you might even be racially, abused.
I don't even think pay is the most important problem. It's not pay. It's a sense of purpose. When you work back here in Nigeria, as you probably would know, working into any government hospital or even private hospitals, there is a despair with which we practice back home. It's ridiculous. You practice literally like a quack in spite of your training. Some of the most basic things that should be available to you to deliver something you would call a professional and equitable service are absolutely glaringly absent. As a house officer, I remember how when I was doing pediatrics, I used to carry babies who had become asphyxiated, so they were suffocating. I used to run with the babies because there was no oxygen in the pediatrics cable. And I would run across to the theater, the surgical theater, where they had oxygen, to try and pump in oxygen and get this child, save that life. Who does that?
This is another angle you've just raised by talking about this is the mental health of a lot of doctors. I was reading an article where a doctor shared, so they were highlighting some of the reasons why doctors are leaving, and aside speed, they talked about the way in which doctors themselves are dying whilst trying to preserve the life of others. Reference was made to the unfortunate demise of Dr. Waire, and I don't know if much has changed since she passed. And then another doctor had shared her experience where she mentioned the exact same thing, how she started to feel depressed because the basic things she needed to practice, like cotton wool, was not available, and how patients would be made to buy cotton wool, and how people died because of things she would refer to as avoidable deaths.
I don't think you have enough time on this show to explore that. Let me tell you that every day a doctor, particularly in public service, in this country goes to work, the committed ones at least, and stays at work to work. It's an assault on your entire well-being. There's nothing more traumatic to see needless death. Needless death. I've been in a situation in the hospital where a child comes in, mother is sick, child is sick, post-childbirth. Child needs something, some blood, some medication. Mother needs some medication and all of that. The father has come, of course, penurious. And this is the bill he needs to pay just to buy the medication. Forget about admission and all of that. Medication just to save the child now. He's walking around, I'm saying, I need to get stuff for you. Where are you? Buy this prescription stuff. And he comes and he says, Oga, please, which one is for the child, which one is for the mother? And I said, what's the point? He said, I don't have enough money for all of this. Let's save one. I cried. I instantly cried. And I just told my colleagues, I said, how much do you have? How much do you have? We bought the medication and tried to save both. We succeeded that day. But that was that day. I'm telling you about the conditions we face daily. There's so much wrong. Our healthcare financing is in the gutter. Has been there for too long. Strategically, there is no real direction for our healthcare. So it's not just pay, it's not even pay, even training opportunities, upskilling. This is a high technology environment globally. We are so left behind in Nigeria by the gap and the pace of change. That I could go to an international conference and after 5 minutes, I'm lost.
And you're lost not because you just became a doctor last week.
Jesus Christ, I've done this for 24 years. And yet, just to keep in touch. So I travel regularly to attend just to say, hey, the thing, I'm like, my word, okay.
So this is what is happening.
Exactly.
Wow.
Probably a good time to also mention, the change. I mean, this is not for the doctors now. This is for the patients. There's a particular antibiotic. I can't call the name on TV, but the particular antibiotic is like 3,005 or so, maybe a couple of years ago.
Augmented.
Now is 50-something thousand, and that is just one.
Have you tried to buy a Ventolin inhaler recently?
No.
Do you need asthmatic? As a friend, sister, brother?
Yeah, I know someone who is.
Call the person. It's moved from 4,000 to 70K because the company has stopped bringing it to Nigeria because of the variation of the dollar. It moves too much, so they can't plan. So Nigeria is out of their radar. But people need this every day.
It's a really sad reality and a sad picture that's being painted. Unfortunately, as we're talking, some doctors are migrating. Some doctors are planning to migrate today, tomorrow, and the day after. People will keep migrating. But you made reference to health financing. And I'd like us to talk a little bit about the budget. Now, the 2024 budget has, of course, the budget has been dubbed the budget of renewed hope. And part of the allocation for health is, I think, roughly 1.33 trillion naira, which comes to about 5% of the budget. What would you say, first of all, is this a decent allocation? In 2023, I think sometime in July 2023, we were promised that the allocation to health will increase to 10%, but it hasn't happened so far. So is this 5% a decent one? If not, what is the actual recommendation for the budgetary allocation to health?
The point about the budgetary allocation and the ratio as a marker of if we're serious, it's not. You know it's not. The money hardly ever truly comes and translates to anything on the ground, number one. I tell you, I have friends, where I am right now in my career, is my friends that are CMDs. They still pay bribe to get the allocation. Come on. Let's get serious. The solution doesn't lie in that budgetary allocation. It doesn't. It's never done. It comes down to information on your point on one side, but let's even leave that completely. Let's leave the government completely. Nigerian government, I mean, why are we talk about government? Decades long, they've shown ineptitude in dealing with things of this scale. What the government needs to do is enabling platforms. Admit the ineptitude, come to the people and say, in this society, how can we do this? A simple example is the health insurance scheme. For all of the time the NHIS has been in play, we're still sub 15% subscribed. So 85% of people are still doing out of pocket. That is catastrophic. It means that if you have a serious medical emergency, you're selling land. It means that any real medical intervention you want to do that's serious, major to serious, would require a significant shift in your economic base if you're anything from the lower three social classes.
Even the middle class, you're just one illness away from being...
From penury.
Exactly.
And over time, I don't think there's been, proper information on the NHIS. Everyone just knows, they know the term, but nobody knows what it does or what it exists as.
And that's part of the problem.
So from your prediction, do you believe that as long as there are countries to migrate to, Nigerian doctors will continue to migrate? And we're talking doctors, nurses, dentists, physiotherapists, laboratory scientists, everybody.
13,000 health practitioners in 2022 went to the UK alone. It will continue. Ali Pate just said we need 400,000 medical practitioners, the broad stream of every kind of specialty, to even begin to just even arrest the slide in the quality of healthcare. It will take us about 20 years to get there. But let's even leave that apart. That will continue to happen. And that's why that's not the fight. You can't fight it. An average doctor in the US earns $240,000 a year. Entry. You want to know what they earn in Nigeria? In the order of $3,000 a year. $3,000, a month. So that's $20,000. A magnitude of 10. How do you compete with that? You get into the US for this program. You register in, you are certain that...
So even $3,000 a month you're talking about, that's a really rich doctor.
So
that's a rich doctor. That's not the average. I don't think that's the average.
I'm talking purely from the government, federal government paid doctors. I'm sorry. I struggle. I don't want to talk about my private doctors, what my colleagues even pay junior doctors in their
But even the federal government paid doctors.
Like
$3,000?
$312.
Sorry.
Not $3,000.
That starts
300.
is
Yeah, $300.
naira.
Yeah, okay, that sounds more like it. So $300, 300.
I'm sorry, my
yeah.
math was wrong.
Yeah, so I just wanted to.
My math was wrong. Forgive me.
Because I would have gone
It wasn't my
medical
strong
school
point.
now.
I've been
Straight away.
an engineer if I was doing math at A1 level. I'm really sorry about that, but it's the math.
Yeah.
But my point is that it's not comparable, and you cannot bridge that gap. So don't fight it. Here's what we need in this country. Have a crisis situation, call everybody. Fantastic Minister of Health we've got now. He's a tried, tested, proven administrator, but we are in a country that's too politically woven in the wrong direction. So sometimes allow our best, be our best. Call everybody, sit down. What do we do? There's something called brain gain or reverse brain drain. We need to aim for a reverse brain drain or a brain gain, something like 10, 15, 20 years down the line. It's the only hope we have. Don't fight this one, it's gone.
Do you feel like the current leaders, especially in the legislature that we have, are very well aware of the problem and are passionate about solving it? And I ask this because very recently we're having conversations about a certain bill that was trying to be pushed to ensure that doctors will work for 5 years in Nigeria mandatorily before getting their license. Of course, that didn't fly. But from the body language that you see from the legislature and from the executive, would you say that they are prioritizing, or they look like they will prioritize the medical professional, the healthcare?
They're going about it the wrong way. Some may understand the problem, but there's a need to grandstand. You can't grandstand what is like a cancer. You can't grandstand a tumor that's already metastasized. You need to come back to say and look and admit failure on all levels of dire proportions. And then come back to say, what can we do? And here's a few things in my head. I've thought about it so much because I've lived abroad, I've worked abroad, I've come back to Nigeria, gone back again, I've been in Australia, I've been in the UK. And I'm saying that, what do they do? Why are they doing what they're doing? They are strategically looking for a way to stem their own tide long term. They have an inverted pyramid for their economy. Old population, much less people under, so the pyramid is beginning to invert. They're fixing that with our people, with our best, to form their periphery, to keep the pyramid that way. Strategic. They're thinking 20, 40, 30, 50, 20, 50 years down the line. They're not producing children as much as they should. So they're saying, you come in, come and work for them. Good skilled people. Come and give birth to people who will be their citizens. And that's why in pre-nursery and nursery, they brainwash the Nigerian kids who are born from Nigerian parents and telling them, you are Canadian, you are Australian. They do that very deliberately. Not to worry, that's going to play out in a few years to come. But let's come back to the Nigerian situation. The Nigerian situation means that you come back and you ask everybody, ask the health insurance provider to step in. They've got financing, but they have to see the end. They have to see some cash out of it. That's fine. Ask people to chain up. What did India do? They couldn't fight it. They were worse than we were. They let them go. There are three things I think they need to do. Go back to our entire academic setting for medical training and say, look, our health-related human resources is absolutely an all-time low comparatively. How do we increase that? I'm not saying multiply the number of medical schools, but you must allow medical schools expand, allow maybe new institutions, encourage them. I'm not saying drop the threshold for standards, but I'm saying actually actively encourage. Don't block them. And then you can find a way to say, can we produce some kind of base standards that can help them get more people in practice into profession? We have to do that. Begin to think about, when I tried to get a place to practice in the UK, one of the reasons they held me back for so long was they had to be sure I had a number to come as a consultant at the end before I could get into training. So they don't have a place for you. They won't take you in because they know that you're going to go and form a glut at the SRO level, what we call a specialist register level. So that's long-term thinking. They didn't need us that much then. Now they bent everything because, I mean, everybody's promised study needs to expand the NHS so much. So that's what I'm talking. Come back and ask ourselves what the problem is. We're producing 3,000 doctors a year. That's an estimate as overestimation. 3,000 doctors a year. To stem a glut of, you're losing nearly 2,000-3,000 a year. So you can't balance it up because these ones are experienced, trained, specialist level, all of that. It takes off roughly about 12 to 15 years to train a proper specialist doctor. 15 years, and you lose him in 6 months. There's nothing that's been done to encourage. And sometimes, like you said, it's symptomatic of everything else wrong with the country. That's why I say you can't fix it in isolation. But in fixing the medical problem is to come back, and I say this over and over again, our health systems need to be strengthened in certain very creative ways. One, the pipeline coming through. Be aggressive, keep your standards, yes, but encourage institutions to produce more. They have to. Nurses, doctors, pharmacists, the entire chain. Encourage aggressively, expand medical colleges. They have to. That comes through. We'll still lose. Attrition will still be great, but the throughput begins to improve. That's number one. Number two, you come back and you ask yourself, one of the things India did very smartly was they lost their best. No doubt about it. They'd gone to India, the good life in the US and everything. And because there's so much more a focused society, what I mean, an Indian guy who's an accountant, for example, he's been counting all the way through, where a Nigerian guy who's doing Owambe and then coming back to the accounting. So attitudinally, they were more, they were harder workers. That's the simple truth. But more importantly, when they started getting to the top levels, they started trying to interest them in coming back home. One of the things they did was to offer them interest-free loans to come back as consortia to set up, replicate that kind of. So the medical tourism thing in India isn't just about tourism. It was dragging back their best to have something that brings them back. You would hear many people who are Nigerian, who've gone abroad, who once they hit 50, the question in your head is, do I want to die here?
Yeah.
Because when you get very senior, very often, you can have the position, but you're not really integrated. That's the simple truth. There's still subtle racism all over the place.
Yeah.
You cannot be the core big dog in that institution easily. Some
No matter
succeed.
how,
Some
there's
succeed,
a
but
handful of people.
Yeah, absolutely. So my point is, at that point, a guy has accomplished, he's got money, he's used to a certain kind of lifestyle. What can he do back home? Altruism becomes a key part of a man's life as he gets more accomplished. What do I give back? What do I want to live for? What do I want to be remembered for? What India did was give the interest-free loans, bring them back. That's how Apollo was born. That's why all those medical chains were born. They brought the same standards. The government insisted that it had to be the same standards, provided basic finance. So they could provide the land for you, for example. They could provide even staff for you. But you have to bring that. And then they found creative ways to finance. Yeah. So he came back, started working on all of that, number one. Number two was they asked them, please come back and teach for 6 weeks in a year. Share that bit. You got a neurosurgeon who's out there in Atlanta who comes in for 6 weeks or 8 weeks in a year and says, I want to just touch on neurosurgery for my guys who train in India. And he spends time, does, first world surgery back there and then trains, because it's like engineering. Sometimes medical practice is basically the same. Human body is human body everywhere in the world. But this technology and all of that changes the way we approach it in different climes.
Right. And just to really just mention that Nigerian doctors are doing amazing. You would hear stories of people who leave Nigeria to go do surgeries abroad, and the doctors there are Nigerian doctors attending to them. Yeah. So yes, we must really applaud our Nigerian medical personnel. I want us to go back to the conversation about the health insurance and how effective it is, just for people who probably don't know much about it. There are many people who work in organizations where their organizations have registered them for some measure of health insurance.
Yeah, some private, health insurance.
The current situation, I don't know if you have enough information about how the health insurance, national health insurance is being run, who is eligible to be a part of the national health insurance scheme, and how people can go forward with ensuring that they are registered.
So the national health insurance, that's the NHIS, is a body that is of a dual role. It's the regulator as well as the primary vehicle for provision of health insurance for government workers. Yep. As a regulator, I don't want to comment too much, but they're not effective enough. That's the simple truth. Go to their website, they don't just tells you this is not something that's really, sort of up to date and effective. But I don't want to go into that too much. But they should regulate better. The government side of things, I don't even think they should completely let go of doing health insurance themselves and just oversee it. What needs to happen is that the private providers, we've got about 81 ever licensed insurance providers in Nigeria. About 40-something of them don't even have valid licenses anymore. Some are still operating. So the point is, get that sector. The system should be straight, standards should be clear, but get them to step into that gap in a way that makes sense and makes money for them. What it does for you is, I go at the beginning of the year and I'm saying, for my daughter, for my sibling, for myself, for my spouse, I'm paying X amount of money. For some of them are really, really not so expensive. But what is the content and what is the guarantee that they will deliver the quality of healthcare that is inscribed in the package? Some are much better than others. Yeah. And those ones that are better, we should allow to, expand better, unfettered. Those who are found to literally fraudulently operate the scheme should get either blacklisted or kicked out. And let the guys who do this thing properly and professionally be the ones to take us to the next level. Let that field expand. That's one example about health financing. I'm saying that we need to get out of pocket spend for healthcare in Nigeria.
Because the number of people can't even afford healthcare. It's even the people that have not even seen food to eat.
Absolutely.
Are the people you're trying to tell to afford healthcare.
There has to be a lot more, information put out, with the NHIS. And of course, like you said, if it needs to be restructured, if it needs, that the whole format with which it is run needs to be changed, then that has to happen.
And I don't know if we can get to the point where even those who are not government workers, even those who who are not gainfully employed, can get healthcare, because
no, but they can.
They can, right?
It's all over the place. But the point is that, like he said, information, understanding, and all that. I'm running a program currently where I'm trying to get 70,000 people registered onto an insurance provider program.
Yeah. All right.
It's a game changing for them.
Yeah.
All right.
Can you hold on? Just to quickly, add this. This is still part of the conversation on Japa. Like I said, it's not just in the health sector. The Academic Staff Union of Universities, has also raised the alarm that most departments and units in Nigeria's public universities were short-staffed due to the resignation of lecturers in search of greener pastures. The chairman of University of Ibadan, chapter of ASU, Professor Ayo Akinwole, disclosed this in Ibadan, Oyo State, saying that Nigeria's public universities were in very pitiable conditions with stress and frustration visible on the faces of poorly remunerated lecturers. According
to him, except President Bola Tinubu arrests the situation by reviewing the conditions of service in terms and salaries, allowances, and infrastructure, many good hands will continue to resign and leave the country. Akinwole added that poor and delayed salaries, unpaid allowances, poor infrastructure, lack of respect for the academic community, and the seeming dwindling hope are some of the factors responsible for the resignation of lecturers in the past few months. I mean, this is something that my colleague had said. It's not just the medical sector. It's the health sector. Sorry, not just the health sector. It's also education as well.
This is, and probably a final question, final statement for me. What we're talking about is the actual reality of where Nigeria is in 2023. This is the effect of probably the past administration and what it did to Nigeria. I'm sure in this room, maybe not you, but if there was a boat parked outside that says, straight journey to wherever, you get citizenship in 3 years, I would take my jacket off and I'll be out of here.
You think I would?
But can you also quickly just speak on it being the reality of Nigeria today?
It is the reality, and perhaps even worse is that it's going to worsen very, very fast. Nothing that goes so wrong starts the year it's happening.
Yeah.
And you said last operation, you have to go back 20, 30 years. But we have to, that's why I'm saying it's an emergency. It's the kind of crisis where you almost call a curfew. Instead of, lock down, call everybody, admit failure, raise your hands and say, let's do. I don't want to hear a white paper.
Yeah.
I'm saying, guys, in real terms, and you must make it worthwhile economically for the players. It is possible because we have the people and the market. And honestly, it's not just the money people go for. It's a sense of purpose.
And the security, just being able to have a decent life. I mean, this is a conversation that we cannot exhaust. Dr. Nsikak and Ntia, thank you very much for joining us today on Breakfast Central. And we'd like you to join in on the conversation as well. Our social media platforms, News Central TV is where, you have all this information. We'd like to hear your thoughts as well. And just in case you've jackpad or you're planning to jackpad, share with us your journey as well.